Welcome to Simply Women's Health with CJ. I'm the host of the show, CJ, and I am a board-certified women's health nurse practitioner with almost 20 years of experience. I currently work in a women's health clinic, caring for both pregnant as well as non-pregnant patients, and I also act as a preceptor for nurse practitioner as well as physician assistant students. Today we're going to talk about pap smears, the who, the what, the where, the why. And this video is directed at you, the clinician. So a little bit of history about pap smears. We've been papping women since about the early 1960s. And when paps originally came out, we were papping women every single year. And women came to the doctor's office every year because they knew that they needed to have their pap smear. In about the late 90s, early 2000s, after compiling decades worth of data, a set of guidelines came out that were released in 2007 by the American Society for Colposcopy and Cervical Pathology, ASCCP. The ASCCP guidelines were very simple. You did not pap anybody before the age of 21, regardless of their sexual history. The only caveat to that is if you have a patient who is HIV positive, their pap screening is initiated within 6 months of initial sexual contact. So between the ages of 21 and 30, you get a pap smear every 3 years. If you have abnormal cells, then they do a reflex and they look for the presence of human papillomavirus. After the age of 30, you get a pap smear, and the provider has the option of ordering an HPV co-test. If both of those are negative, the pap screening is every 5 years. Those guidelines have been adopted by both the Joint Task Force as well as American College of Obstetrics and Gynecologists, ACOG. There is another set of guidelines that have been put forth by the American Cancer Society. Those are also perfectly acceptable. It is very dependent on the provider preference as to which set of guidelines they choose to follow. The American Cancer Society recommends delaying initial pap screening until 25 years of age, and when they do paps, they do a pap with a co-test starting at 25 years of age. So, all of that being said, pap smears, the purpose of a pap smear is to look for cervical cancer. Really, we're looking for the presence of human papillomavirus, HPV. HPV is what causes 99.9% of cervical cancers. So your patient comes in and they get their pap smear. A couple things. If they are on their menstrual cycle and they are bleeding heavily, that's not necessarily the best time to get a pap smear. If they are just having a little bit of spotting, you can certainly take a swab and wipe away the excess blood and get your sample. The patients don't like pap smears, and that is very understandable. If you have a patient who has a history of any kind of sexual trauma, they may not tolerate the pap screening very well. So you've done your pap, you've sent it off, and now you've got your results. Results are managed, the gold standard is through the American Society for Colposcopy and Cervical Pathology, again, ASCCP. If you are a provider who performs pap smears, it should be mandatory that you have the ASCCP app either downloaded to your phone or to your desktop, because that is how we manage abnormal pap smears. It's a very simple app. You get it from the Google store. It's $9.99, and you just you pull up your app, and the app walks you through the process. They want to know the age of the patient. They want to know the pap result, the current pap result, and any previous pap results, and if there's been any kind of diagnostic procedures done on the cervix. And then it just walks you through the process, and the app will tell you what the next step is, whether or not it's to repeat the pap again in a year, 3 years, whether or not the patient needs a colposcopy. Colposcopies are for those patients who it is determined that they have a 4.3 or better risk for developing CIN3 over time. So, okay, so now you got your pap, you have an abnormal result. You called your patient, and or you brought her in and you need to counsel her. So whenever I get a patient that comes in who has an abnormal pap smear, I sit them down, and you have to understand, a lot of these women, there is just very little information out there. So they have gone online to Dr. Google, and now they are pretty convinced that they have cervical cancer and they're going to die. So after you calm them down and say you don't have cervical cancer, I will usually just draw a picture of a cervix. So I draw my little cervix, and I always give the disclaimer, I'm a nurse practitioner, I'm not an artist, so bear with me while I draw my little pictures here. I draw a picture of the cervix with the endocervical canal, with the vagina around it. And I explain to my patients that the way that the cervix is made, the cells closest to the surface of the cervix are very, very flat in nature. And as you go down into the cervix, they get a little bit bigger, a little bit bigger, a little bit bigger, they get a little bit bigger, and then they become ginormous. I explain we take paps, we take cells off the top, we take cells from the inside, and we send them off to a cytologist, and then the cytologist will give us a diagnosis, the best being normal, the worst being cervical cancer. Along the way, you have your different diagnoses. The first is ascus, atypical squamous cells of undetermined significance. Ascus, as a rule, tends to sit real superficially on top of the cervix. Some would even call these inconclusive cells. So the cells, they're flat, but they just don't look quite right. For the patients in between the ages of 21 and 30, I typically order my PAP with reflex testing. So if it comes back with ascus, they will reflex and they will look for the presence of human papillomavirus. Next level up is LSIL, low-grade squamous intraepithelial lesion. Low grade, by definition, goes a third of the way into the cervix. So the cytologist will see these medium-looking cells. Next level up is HSIL, high-grade squamous intraepithelial lesion. High grade, as a by definition, goes 2/3 of the way into the cervix. And then you have your worst cells, your carcinoma in situ. Carcinoma in situ goes all the way through the basement, and the cytologist will see these gigantic cells in their entirety. So patients who are less than the age of 25, who have ascus, those patients will often have a repeat PAP in a year. After the age of 25, ascus with any kind of positive HPV or anything above that leads to, the referral is for colposcopy. So you've got your abnormal PAP. I will usually tell the patient, look, this is your diagnosis. You have a low-grade PAP. Low grade because that is between the ages of 21 and 30. That is automatically assumed to be HPV positive. So the patient comes in. I'll draw my little cervix. I'll tell them which one they have, and then I will explain to them about human papillomavirus. HPV, again, is responsible for 99.9% of cervical cancers. There are approximately 200 strains of HPV that affect the human body. Of those, 40 are known to affect the reproductive system. Of those, 14 are known to cause cancer. We have two strains, number 16 and 18. 16 is responsible for 50% of cervical cancers. 18 is responsible for 20% of cervical cancers. And if you're keeping track at home, 18 is actually more associated with glandular cancers as opposed to squamous cell carcinoma on the outside of the cervix. We have a new player on the field, number 45. She's being implicated in 5% of cervical cancers. So right there, you've got 75% of your cervical cancer-related HPV strains. There are 11 others. So when you do your HPV co-testing, they will usually break out 16, 18, and 45. And if the patient tests negative for one of these three, then they are just thought to have a positive co-test, and they really don't break out those other 11 strains. So for the patients that require colposcopy, so those are done typically by an OBGYN or somebody who's gone to class and become certified in colposcopy. When a patient comes in for a colposcopy, a couple things. First of all, again, they cannot be on their menstrual cycle because the menstrual cycle will just obliterate, the blood will obliterate the cervix, and you can't see what you need to see. We do not want them to have unprotected sex for 2 weeks prior to coming in. And ideally, I like for them to take some form of an NSAID an hour before their appointment time, because it is a little bit on the crampy side when they have this procedure done. They'll come into the clinic. We do a pregnancy test. And then we will counsel them and consent them because it is, we are going to be doing, typically we do biopsies. So what is a colposcopy? A colposcopy is a fancy word for we're going to look at your cervix with a standing microscope. So after I've drawn my picture, I also draw a cervix for the patient and say, okay, so now I'm going to be looking at your cervix. This is looking at your cervix from the side. This is looking at your cervix head on. I put the speculum in. I look at your cervix. And I'm going to look for your transformation zone. The transformation zone is just that. So the cervix grows from the bottom to the top. The cells start out at the bottom. They're big and round and fluffy, and as they migrate towards the top, they get smaller and smaller and flatter and flatter. When they get to the top, they come through the endocervical canal. They come out to the edge, and they die off. That typically takes about 2 years from here to here. So the cells inside are called columnar cells. When they come through the endocervical canal and they come out, they become squamous cells. The difference between a squamous cell and a columnar cell is squamous cell has a protective coating on it, so the HPV really can't get in there. So the cells that are transforming from columnar to squamous cells are in what's called the transformation zone. Those are your vulnerable cells. So put the speculum in, you clean off any excess mucus that's in there, and you're going to look for, first you're going to identify your transformation zone. Then we're going to put vinegar on the cervix. The vinegar has to sit there for 1.5 minutes. Some people say it's cold, some people say it stings. Most people say they don't feel anything at all. The vinegar does have to sit there for about 1.5 minutes, so I'll usually just sit there and make small talk while I watch the clock for 1.5 minutes. Then you take your swabs out and you look with the standing microscope at the cervix. And what you're looking for is cellular change, primarily what's called acetoid epithelium. HPV reacts with the acetic acid, which is basically just vinegar. It reacts with the acetic acid, and the abnormal cells will actually glow white. Then we can also take and put another solution over the top of the cervix called Lugol solution. Lugol solution provides a nice border. So let's say you come over here and you've got some faint little borders. You put the Lugol solution on, and it very clearly defines where the lesion is growing and where you need to biopsy. When you biopsy, you take a Tischler, and you take a little bite of the cervix. I tell patients the bite is no more than a grain of rice. It's not a huge chunk. It's just a little piece of the cervix that you send off for pathology. You're also looking for what's called punctation, where it looks like somebody took and poked holes in the cervix with a pin. We look for mosaicism, which looks like a mosaic tile pattern. Then we'll also flip on a green light, and green light helps us to identify any blood vessels, because as we all know, cancer needs blood flow to grow. If you see anything suspicious, again, you take your biopsy. Now, remember, you can't see inside the cervix, and these are very vulnerable cells. So we also take a little, it's a long stick, and it's got a little tiny basket on the end of it. It's maybe 2 millimeters wide. You go into your endocervical canal and you scrape. Take a brush, gather up those cells, and send everything off for pathology. That's the part that actually hurts. People think that the biopsy hurts. Most of my patients don't even bat an eye when I do a biopsy. But you do that ECC, they're not very happy with you for a few minutes after that happens. So you send your pathologies off, and you get your results back. When we get our results back, the results are going to be either negative, CIN1, CIN2, or CIN3. Negative in CIN1, CIN stands for cervical intraepithelial neoplasia. Instead of calling them squamous cells, now we're calling them, we're actually identifying them as cervical cells. Negative means really no appreciable change in the cells whatsoever. CIN1 is very mild changes. Those are repeat PAP in 1 year. CIN2 those are more moderate changes, and CIN2, we kind of have to look at the patient's particular situation. Is the patient planning on having a baby anytime soon? Is she young? If they're young, we really prefer to not not interrupt the integrity of the cervix if we don't have to, especially on young patients who have future childbearing plans. CIN3 is a lot more worrisome. These are more severe cells, and these probably will want to be removed. How do we remove it? Two ways. You can either do what's called a cold knife cone, or you can do a LEAP. LEAP stands for loop electrical surgery excision procedure. Basically, you numb up the cervix. Some people do this in the operating room with a patient asleep. Some places they just do it in the clinic with a pretty powerful block. They block the cervix, and then they take a D-wire and they go in and just remove a portion of the cervix. And again, send that off for pathology. If you have a patient who has had a LEAP and you're looking at the results, you want to see a couple of things. First of all, what was the grade of the cells? Was it a CIN2, CIN3? And most importantly, are the margins free of dysplasia? Because if you do this and there is still dysplasia in the margins, there's a chance that the surgeon didn't get everything when they did the procedure. And then once the patient is cleared of their LEAP, again, you go back to your ASCCP guidelines and you follow their directions as far as future Pap screenings go. So that's basically Pap smears in a nutshell. If there's anything that you would like to hear about, I've got my email address up here, simplywomenshealth2023@gmail.com. I would love to hear from you if there's any topics that you would like to hear discussed on this channel. I'm also available on both Facebook as well as Instagram. My address there is CJ, That's all I've got for today. Until next time, I'm CJ.